Hey, welcome to Capturing Christianity. My name is Cameron Bertuzzi, and today we're talking about COVID vaccines and skepticism, actually, toward the vaccines themselves. So there's a guy who I've got on the channel with me. His name is Sy Garte, and he and I did a video. It was about 3 weeks ago at this point, the point of this recording. 3 weeks ago, we posted a video. It was actually recorded at our CCV1 conference that we did back in August of 2021, and I asked him, we were recording some interviews, and I just asked him, hey, would you take a couple minutes and just talk straight to the camera and just talk to people about the vaccines. So it was kind of an off-the-cuff thing, and he did it. He was very gracious about it. So when we posted the video, it got a really negative response, to put it mildly. There was a very interesting response. I should have anticipated it. But anyway, so what we've done today is, in this video is sort of linked to this other video, but we've invited an immunologist, Dr. James Ussher. I should have asked you before we started this recording. Is it Ussher or Ussher or something else completely?
It's Ussher. Yeah.
Ussher. Okay. Yeah. Well, so we've got an immunologist with us on an expert in immunology. So this should be a really good discussion. What I did in preparation for this interview, this sort of joint interview, was I asked the audience. I asked in a community post on the YouTube channel. I asked you, what are your objections to the COVID vaccines? Because I've noticed that this, like in the Christian community, this is a very big deal. There's a lot of Christians, especially in America, that are against these vaccines and are very skeptical of them. And so I said, well, let's just have an expert on in immunology to talk through some of these objections. And so that's what we're doing. And so I've collected these objections from you. And I put them in a document, and some of the questions, obviously some of the objections, there's a lot of overlap, and so I tried to just have a few questions. Well, really, there's actually I think a total of 12 or 13 total, but a lot of the objections were along the same lines, and so but we're going to be covering a lot of ground today. But first, what I want to do before we get into the actual meat of the conversation is allow both of my guests to introduce themselves. If you don't know who they are, let's start with Sy. I mentioned you first, so I'll let you go first. Sy, introduce yourself to the audience for anyone who doesn't know who you are.
Hi, yeah, my name is Sy Garte. I'm a PhD biochemist. I'm currently retired from academia, where I spent about 30 years as a professor. I then worked at the NIH for about 6 years, and now I'm retired. And I also, later in life, converted to Christianity. I've been very active in Christian apologetics, mostly related to science and biology and biochemistry. And I guess that's enough. Okay.
It could be considered enough. You know what I was thinking about, Sy? I was like, man, I wish we could go back to that room with the lighting and stuff that we had set up, because This just looks so much different from the lighting and stuff that you've got in your office. It was so epic, and a lot of people were saying it looked like Star Wars kind of, but and that's all I could think about when I had you full screen just now. All right, well, let's get over to James. So James, go ahead and feel free to introduce yourself to the audience.
Sure. So look, thanks for the introduction. So my name's James Ussher. I'm medically trained and from New Zealand. My clinical specialty is in microbiology, and I've done a PhD in viral vaccine vectors and postdoctoral training at the University of Oxford in cellular immunology. I'm an associate professor at the University of Otago in Dunedin, New Zealand, right down south of New Zealand in the Southern Hemisphere. I'm the science director of the Vaccine Alliance Aotearoa New Zealand, and I've been involved in the COVID vaccine response in New Zealand, been on the government's vaccine task force last year, and now on their vaccine technical advisory group. From a Christian perspective, I'd just say from a Christian perspective, so I became a Christian after medical school. So like Sy, came to faith later in life, came from a position as an atheist, and was converted in Oxford, in the UK, and have been a Christian for almost be 20 years now.
It's great. Yeah, it's really great to have you on the channel. A friend of mine, a a joint friend of ours, I think. Is Zachary Arter? Is he a friend of yours? Do you know him? I know he's from New
I
Zealand.
don't know, Zach.
Okay, yeah, you're both biologists. He's great. He's awesome. So yeah, but it's great to have you on the channel. Let's jump into the content for today. Then the first question, you feel free, both of you can jump in if you want to. But the first question that I've got here, or question/objection, is why didn't you invite a vaccine skeptic onto the channel for the stream? So this was one of the primary objections that was raised in the video that Sy and I did together. Well, really, it was just Sy in the video, but we recorded it. This was one of the top comments that was made. And what's interesting about this is that when I make a video, say with another Christian, and we're critiquing some kind of atheist video, or we're making a response to it, this is actually one of the objections I get from atheists sometimes is, why don't you have an atheist on another perspective on to respond or give their thoughts, you know? So it's a common objection that you get on at least in, you know, the apologetic sphere. So I want to say that no YouTuber, from my perspective, no YouTuber, no Christian YouTuber, atheist YouTuber has an obligation to have on someone that disagrees with them in a video like this. There's no obligation to do that. There's a couple of reasons for this. One of the reasons that I highlighted in a comment that I made on the video with Sy was that you may think that, you know, there's only two perspectives, right? There's the pro-vaccine perspective and there's the anti-vaccine perspective. But there's other perspectives, like someone who's just sort of, you know, unsure about what to think about it. So if you want to say that you've got to have some other perspective on the channel, why stop there? Why stop at only two perspectives? Why not just go to three, or maybe some other perspective? I don't know. So that's one concern. Another concern is that there's other ways to have your own view, which if you're like against the vaccines, there's a way to have your voice heard, and that's to make a comment. That's to post your own video, start your own YouTube channel, and respond to this video. There's ways to get your voice heard, other perspectives heard, and it's not always the responsibility of this one YouTuber to have on different voices. So there's not much to say beyond this. I just don't think that there's an obligation for YouTubers or for myself to have on different voices. What I do think is going to be very helpful in this conversation today is that we're going to be giving very compassionate responses to these objections, to these. We're going to be looking at the evidence, the scientific evidence for and against the vaccines. So that's what we're hoping to do in this channel, in this episode. So I hope that you can see value in that, even if you don't have, you know, we don't have a skeptic on the channel in that sense. Do either of you have anything to add to that, or should we move on to the next one?
I mean, I'd just make the point that coming from a science perspective, that the vast majority of scientists and medics interpret the science and the data to be supportive of vaccines, and the mainstream scientific view would be held by 99% of scientists and medics. And if we're talking about the science, then I think we should be interpreting the data in a I don't see the point in having that 1% interpretation included in the conversation. I think the vast majority of people would agree with the view that's going to be put forward today.
Sy, do you have anything to add, or should we move on?
Well, I think we can move on. I mean, I agree completely with what James just said, and I think that many of the arguments or the skepticism against vaccines are outside of the scientific realm. There are a couple that are put forward by a few scientists, and some of them have legitimacy, but they're often misinterpreted by people who hear them. And again, most of the objections that I've seen are simply not related to the scientific data. So I agree. I think we can move on after that.
So one thing is, let's move on to the second objection. In this one, I'm kind of gonna lump in a whole lot of different objections into one, and you may be upset at me for doing this, but we're not going to address the whole mandate issue. And the main reason for that is that when it comes to mandates, I see those as distinct from the question that we ultimately want to get to today, which is all about the scientific evidence for and against the vaccines. So primarily we want to focus on the scientific evidence. This is not a political discussion about what should or shouldn't be mandated by some governmental system. So I see a distinction between this. That's more of like a political issue. The mandate issue is more of a political thing, whereas we want to kind of discuss the science and look at the objections, skepticism for the vaccines. Like, are they healthy? Are they unhealthy? Are they hurting people? Are they helping people? That's what we're focusing on today. So if your objection to the vaccines is that they've been mandated, sorry to disappoint. That's not what we're going to be discussing in this episode. So James, Sy, feel free to add anything to that, or we'll move on.
Yeah, look, I agree. I don't, from a scientific perspective, it falls outside of that realm. I think it's a public health and ethical question. So I agree that that should fall outside our discussion.
No, I have nothing to add.
Okay, so let's move on to the third one, and now we're going to get into the meat. I'm sure you've been waiting for that to get to this, but so here's the objection. Some of these, they're all anonymous. I want to say that first. So some people ask that they've got family members who they want to remain anonymous with the questions and objections that they're raising here. Some of these objections come from real people. Other ones I've sort of paraphrased. So, but I think most of them are in the form of a question. So here's the third question. Do you think that a layman should be skeptical of an incentive structure in which a physician cannot be held liable for any consequences of recommending vaccination, but can be held liable for the consequences of not recommending vaccination? So who would like to start on this one? Let's start with James.
Look, I mean, I think this again falls into a political sphere, and I'm not familiar with what the situation is in the United States. Look, I think that on the basis, medicine should be practiced in a scientifically driven fashion, should be evidence-based, and should be informed by the data. I would suggest that the data strongly supports vaccination, and as such, that doctors should be encouraging their patients to be vaccinated. And if they're actively discouraging their patients from being vaccinated, then they're not got their patients' best interests, or they're not representing their patients' best interests in light of the data. And I think there should be censure. But that's a political issue. I think from a scientific perspective, the data strongly supports the vaccines, and that should be informing medical practice.
Yeah, Sy, anything to add on this one? I mean,
well, I think
to me, it's almost I know that the language can sound pejorative. It can sound, I don't know, inflammatory, but this kind of seems like some conspiracy theory kind of reasoning. It's like there's this incentive structure, but what does that actually have to do with the science? There's not a whole lot there. You're just going to be kind of reading into things like there's this big what's the way to put it? Yeah, there's just a big conspiracy going on here with this incentive structure, but it's a completely distinct question from the science. What does the science actually say? Which I think is just another way to reiterate what James just said there. But yeah, go ahead, Sy.
Yeah, I think that it's kind of an extension of what James just said. What the reason that this liability, which is actually a more of a legal issue, but the reason that a physician may be held liable, and I don't know the details of the legality, but for is not going to be held liable for recommending a vaccine, is because liability has to do with best practice in medicine. So if you're a physician and you do anything that goes against best practice, and best practice is clearly known by all physicians in every area, you could be held liable. Whereas if you follow best practice, you're likely not going to be. Now, this is a somewhat political, but also a legal question, which none of us are able to answer. But I think the logic is what I just said, is that it's clear that you have to follow the best practice. And as James said, there's no question that best practice now is for vaccination.
Okay, so let's move on to the next objection, and this one again is sort of a paraphrase, but it's a way of putting an objection or a question that a lot of people raised, and even I've wondered about myself. It was even featured in a discussion by Joe Rogan, and I can't remember the name of the guy that he had on from CNN, but it was a very heated exchange, very interesting exchange. I only watched part of it, but it has to do with the vaccine immunity versus natural immunity. Which one is better? And so that's what we'll discuss now. Before we went live, Sy, you were, or we're not live. I forget that we're switching to this new format where everything is going to be pre-recorded. So I'm gonna have to update my terminology. But Sy, we were talking that there's a study that just came out, and give me the name of it. I'm gonna try to put it on the screen and link it in the description of the video so that people can go and look for it themselves. But we were talking about this study that just came out that was saying that the vaccine immunity is twice as good as natural immunity.
Yeah, this was a study that was published in August, fairly recent, in the Mortality and Morbidity Weekly Report, which is something put out by the CDC, and it's in the form of a published paper. It's peer reviewed. There are several authors here. The first author is Alison Cavanaugh, and it's called Reduced Risk of Reinfection with SARS-CoV-2 After COVID-19 Vaccination. And what it is a case control study, which is a kind of study done in epidemiology where you compare two groups of people and do a lot of statistics and come up with whether or not there are differences between those two groups in whatever outcome you're measuring. In this case, everyone in the study had been infected and had COVID-19. One group got a vaccine afterwards, and the other group did not get a vaccine. So the comparison is between vaccinated and unvaccinated people, all of whom had natural immunity from having gotten COVID. And it turned out that those who were vaccinated were twice as protected as those who were unvaccinated from a second infection. So it looks as if there is a benefit to getting the vaccination, the immunity from the vaccination, on top of the immunity from the natural immunity of getting COVID. But there's more to this story, which is that, natural immunity sounds great, but what you have to remember is that the only way you can get natural immunity to COVID-19 is to get the disease. And that, of course, has a high risk of serious illness and death, whereas vaccination, the risk is nothing like that. And we'll probably get into relative risks and benefits later. But just talking about natural versus vaccine immunity, it seems that even in this case where you're dealing with people who've already had the illness, vaccination is still better than just having the natural immunity by itself.
James, is there anything that you have to disagree with what Sy just said, or do you agree with everything?
Well, look, no, I agree. I mean, I think if it's what so there's Shane Crotty and Alex Setti from La Jolla Institute like talking about hybrid immunity, and that's where you've had the natural infection, then got the vaccination, and that does appear to be the broadest immune response. However, to get, as Sy said, to have natural infection, you have to you're running all the risks of being infected with SARS-CoV-2 and of COVID. So I think definitely the safest and advisable route is to have vaccination, and that provides excellent immunity. And there's good data that's coming out now that's included after the mRNA vaccines, showing that you've got excellent long-lived immune responses, good memory responses with good breadth after the vaccines. So I think it's not a comparison that's in some ways it's an interesting scientific comparison, but when thinking about what you'd rather have, I think there's absolutely no question that it'd be better to have the vaccine and avoid getting natural infection. But if you've had natural infection, as Sy has mentioned, there's now some good data suggesting that there's a great benefit to getting a vaccine on top of that to improve your not only the breadth and strength of your immune response, but also now emerging data showing increased protection.
So one thing that I was thinking about in Joe Rogan's podcast that he did, he was he was just talking about how natural immunity seems to be stronger, which the study seems to suggest otherwise. But when it comes to the monoclonal antibodies that a lot of people are getting for treatment, which we're not going to be discussing a whole lot of treatment options today, or we're mainly going to be focusing on the vaccines. But if you're worried about the sort of vaccine versus natural immunity, does it make sense to be concerned with monoclonal antibody immunity versus natural immunity? Because isn't it possible that that's going to have an effect? You're not really doing natural immunity. You're actually getting these antibodies, which could lessen your own natural immune response.
Yeah, look, I haven't seen any studies that have looked at immune response after monoclonal therapy, but I mean it is passive immunity, and it is likely to it may blunt the subsequent immune response. But there's no doubt that monoclonals are highly effective at preventing people from progressing to severe disease. So I think if someone is infected, they've got a positive test for SARS coronavirus 2, you're in that early period, you've got risk factors for progressing to severe disease, then monoclonals are highly recommended as they significantly reduce your risk of progressing to require hospitalization.
Okay, let's move on to the next one, which is just a question. Why do people that already had COVID still need to get the vaccine?
Well, that's sort of answered by part of my answer to the last question, which was that study that shows that you're actually increasing your immunity from the innate immunity that you get from having had the disease. You're increasing it with the vaccines. And what we're now, and James has to talk about this more, but I think what we're seeing is clearly that both the natural immunity that comes from having the disease and some of the immunity from some of the vaccines don't last forever. They wane with time. So if you had COVID 3 or 4 months ago, it certainly is a great idea to get the vaccine now, because that will increase your resistance, increase the amount of antibody, and increase your resistance to getting it again.
Anything on that, James?
Yes, look, I mean, I think we discussed that with the previous question as well. And I mean, as Sy has mentioned, we do see waning immunity, and both with natural infection and after the vaccines, and a booster dose of vaccine after natural infection will significantly leads to massive increases in levels of neutralizing antibodies, and as shown by that MMWR study, increases protection against infections. So I think there's clear recommendation for and good evidence to support a vaccine in people who've had prior infection.
Okay, we're going to transition now to talk about the fact that there's no long-term studies that have been done on these vaccines, which is just, I mean, that's just a fact because the vaccines haven't been around long-term. So here's the question: the vaccines are so new and there are no long-term studies. why should I take a vaccine that has no data backing up its long-term safety?
Oh yeah, well, I can take that one first. So I mean, I'd say that for a start, we have excellent safety data on these vaccines. So I'm going to focus a bit on the Pfizer vaccine because that's the one we've rolled out in New Zealand. And there were over 46 million, take that back, there was over 46,000 people involved in the clinical trials. There has been, last time I looked, over 240 million doses given in the United States alone, and hundreds of millions of doses given in other similar regulatory environments where there's really close monitoring for adverse effects. Despite all of those doses and all of that, and with all that monitoring, we've only identified really two significant adverse effects that are associated with the Pfizer vaccine, and that's the increased risk of the anaphylaxis, which is an acute allergic response that occurs within minutes of having the vaccine. All the vaccine clinics are set up to manage it, and that occurs about 5 per million doses given. The other is the myocarditis, which occurs about 2.7 per 100,000 people vaccinated, higher risk in younger adults who are male, but mostly is mild and rapidly settles. And importantly, I'm sure we'll come back to this later, but the risk of myocarditis with natural infection is several-fold higher than it is with the vaccine. So these are rare side effects that we have identified through our monitoring. We have not identified any other side effects to date. The more doses we give and the longer our monitoring goes, it becomes increasingly less likely that we'll identify new risk factors or new potential adverse effects. But that monitoring is ongoing and looking for potential adverse effects. With regards to long-term adverse effects, what we know from previous vaccines and from first principles is that adverse effects are likely to appear, and in the past have occurred within 6 weeks, 2 months of vaccination. There's no reports of adverse effects from previous vaccines that turn up months or years down the track, and there's no good a priori reason to, from a scientific perspective, to expect that might occur. So the CDC, the FDA, with their review of this of the vaccines, were looking for at least 2 months of safety data before they were prepared to give emergency use authorization. That's because we would anticipate that, as I say, any adverse effects would occur within that time frame. So I think it's becoming increasing as time goes by, increasingly less likely that we'll identify new adverse effects associated with the vaccines. And I think the risk of side effects that occur late after the vaccine is very unlikely. Sy, do you have anything to add to that?
Yeah, on the safety issue, just two comments. One is that what a lot of people don't realize or have been told incorrectly is that some steps in the normal process of vaccine approval were skipped for this vaccine, and actually that's not true. What did happen was, and this was a result of this Project Warp Speed, which was instituted by the Trump administration, that the steps were followed, but there was a compression. So, for example, some of the clinical trials, which are usually separated by a couple of years, were actually done at the same time. Most of the very long time that it takes to get a vaccine approved, a lot of that time is not where actual work is going on, but in between filing forms and filling out documents. And there's a lot of time spent in data analysis, of course, but all of that was done very rapidly. Most of the bureaucracy was stripped away so that it was not necessary to, fill all these forms out. And that was applauded by most people, both scientists and non-scientists at the time, because at that time, the need to get a vaccine into people's arms was recognized by almost everyone except the very militant anti-vaxxers, just a small group. So nothing was skipped. Everything was done that was usually done, and the results were extremely good in terms of safety. I just want to mention about the myocarditis. There was a study done in Toronto, I think it was Toronto, which showed a much higher incidence of myocarditis. It was like 1 in 1,000. And it turned out that report was never published. It was in preprint and it was retracted because it turned out that the authors who admitted this, nobody had to press them. They realized that they were undercounting the number of vaccines that had been given at the time by a huge amount. So instead of something like 30,000 vaccinations, there were 800,000 vaccinations. So the denominator, which had been very small, got a lot bigger, and the risk was like 25-fold less than they thought it was, and what James already mentioned it was. So there are still people who are promoting that fear of myocarditis, and many people, say this is especially a problem for young men. But as James pointed out, the risk of getting COVID is much worse for that same disease than for getting the vaccine. So that myocarditis scare should be put to rest.
What is myocarditis?
Yeah, so myocarditis is inflammation of the heart muscle, and it's it is a disease that's actually more common normally in young males anyway. It's got a multitude of different causes. Many of them are virally induced. I think it's unclear why there's that excess risk in young males, but we sort of see that we see that prior to COVID and prior to the COVID vaccinations. That's the sort of normal epidemiology of this condition. And I'd make the point that yes, while the risk with the risk of getting myocarditis with the vaccine is higher in young males, there's also a substantially higher risk of getting myocarditis with COVID in young males, and it's many-fold higher than with the vaccine. And the myocarditis with COVID tends to be a more severe course than the mild myocarditis that settles with anti-inflammatories with the vaccine. So the risk-benefit analysis or the risk-benefit ratio clearly lies with the vaccines. Just looking at the single issue, and that's ignoring all the other risks of clotting and lung problems and that you get with COVID infections. So yes.
So the next question.
Can I just?
Yeah, go ahead.
Oh, so I was just going to come back to what Sy was saying about the trials as well, and how we managed to get a vaccine so quickly, because I think this is often and this may be, one of the questions that was going to come up, but seeing as we're discussing it now, I think there's been a number of things that have coalesced to allow the rapid vaccine development. So I think the first is the sequencing technologies. So within about 12 days of these cases of the severe viral pneumonia being recognised in Wuhan, China, the sequence of the virus had been sequenced, and that sequence made publicly available. And so those sequencing technologies and sharing of data really enabled that. And then the vaccine companies were able to start making their vaccines within days of that sequence becoming available. Also, I think it's really important to say that this is called SARS-CoV-2 for a reason. It's not the first beta coronavirus that has jumped species barriers and caused zoonotic infection in humans this century. I mean, it's the third. So we had the original SARS virus back in 2002 to 2004. We've had the Middle East respiratory syndrome virus that's been causing a grumbling outbreak since 2012, predominantly around Saudi Arabia. And there's been a lot of vaccine development efforts around both the original SARS virus and MERS virus. And in fact, 2 SARS virus vaccines made it through to phase 1 clinical trials. We saw 3 MERS vaccine clinical trials published last year. And so there's been a lot of vaccine development work that's been done on these beta coronaviruses in the past. So we already knew what we needed to do to make a vaccine against a beta coronavirus like SARS coronavirus 2. We had the sequence early on, and then there's also been a lot of interest in development in these vaccine platform technologies that can be rapidly developed for new diseases. And mRNA and the viral vectors, which have been really the leaders in COVID vaccines, are 2 of those platform technologies. And these platform technologies can be rapidly adapted. You can change the sequence in the mRNA or the viral vector to your new pathogen. And there's good pathways for GMP manufacture. So for good manufacturing practice, manufacture for medical and clinical trial use. So you, rather than taking months to years to develop a manufacturing process, it can happen in weeks to months. And in fact, we saw that with the mRNA vaccines, where they were able to go into clinical trials within a couple of months of the vaccines having been developed, and with the after the preclinical work. So I think that along with the overlapping of the clinical trials and stripping back the unnecessary bureaucracy, and enabled us to get these vaccines in such a rapid fashion. So I think it really is a huge success story for science, and for science done very well.
I'm tempted to ask, how much of this should we attribute to Trump's administration in getting it done so quickly?
Look, I mean, I think we can. I think Operation Warp Speed was hugely useful. I mean, a lot of these trials, particularly for Pfizer and Moderna, were done in the United States. There was a huge amount of money provided that enabled these trials to occur. I mean, I think that's another reason why sometimes the development process is slow, because people are trying to get money and funding to continue development, and whereas money hasn't been a barrier. So I think that, I think President Trump should be credited with the investment and the impetus he gave to vaccine development through Operation Warp Speed. Yep, so I think that's a great success of his administration.
All right, so let's turn to a question that's very related to what we just talked about. So if you have anything to add, feel free, but if not, then no big deal. And this one is, what correlation do the COVID vaccines have with heart-related issues? We've already discussed one of them already. Are there any others? Are there any other risks with heart-related issues that you're aware of?
No. I mean, it can cause. There is the association with the myocarditis, also pericarditis can go along with that. That's inflammation of the sac around the heart. I mean, there's similar entities and often lumped together in these studies. But no, I mean, I think we've covered off the risks and the risk benefit being hugely in favour of the vaccines, even if just considering this one issue.
All right, let's move on to another issue here, which is another central issue. I think why a lot of people are skeptical, or a lot of Christians especially are skeptical of these vaccines, is that aborted fetal cells were used in testing the efficacy of the vaccines. And so is this something that should bother Christians? And this is a question for either of you, but I want to just highlight the fact that, similar to the mandate issue, this is a very ethical concern. And so we're going to be dipping into ethics and philosophy a little bit, apart from science and what are the risk factors and everything. So we're going to be dipping into some territory that maybe both of the guests that I have on today are not necessarily experts in ethics or Christian ethics or abortion, maybe. But either way, I think that we can still talk about this as Christians. So James or Sy, it looks like Sy, you've got something to say.
Well, I think the first thing, you're right, Cameron, that this goes into lots of theological and moral issues. But I think the first thing we should point out are the scientific facts of this issue. And that is that, first of all, there are no fetal tissues or fetal cells in any of the vaccines. However, the J&J vaccine, the Johnson and Johnson vaccine, did use a human fetal cell line in the production of the vaccine, but the Moderna and the Pfizer vaccines using mRNA did not use any fetal cell lines in the production. It's not necessary. Now, on the other hand, as has been pointed out, it is true that all the COVID vaccines, including the mRNA vaccines by Pfizer and Moderna, used a particular fetal cell line called HEK 293 during the early research and development and testing phase. And that's required because before you put any kind of new medication into a human being to test, you want to see if it kills human cells. And the only way to do that is to use a human cell line. I have some experience with human cell lines, so I'll just add a little bit more detail here. It's very hard to make, excuse me, a human cell line that can be used for research where the cells will keep growing, except from two sources. One is from tumors, which tumor cells grow very well, and the other is from fetal cells, where there's a lot of stem cells. Now, the particular cell line, HEK 293, was indeed taken from an abortion that took place in the Netherlands in 1973. At that time, abortion was illegal in the Netherlands except to save the life of a mother. Now, we don't have exact medical records of this particular case, but that we can assume that researchers would not have been able to get that material if it had come from an illegal elective abortion, which was not done or was not legal at that time. So those cell lines, although they do come from an abortion, it was an abortion done to save the life of the mother. Now that may help, and so again, then we get into theological and moral issues. But I thought that those facts should be brought out. The other fact I think is very important is it's not just vaccines that are used that use fetal cell lines to test for safety and test for the early stages of uh, production of medicines. That the same cell lines were also used, for example, to make the monoclonal antibodies by Regeneron, the same treatment that President Trump had when he was struck ill with COVID. In addition, acetaminophen, Tylenol, in other words, aspirins, ibuprofen, Pepto-Bismol, Tums, Motrin, Maalox, Exlax, Benadryl, Sudafed, Preparation H, Claritin, all used the same fetal cell line to be tested. So if you're claiming a religious objection to taking the vaccine because of the use of that cell line, all of those and many more, I just read off the most well-known ones, are all, you would have to stop taking all of those medications as well to be consistent. So this is something that a lot of people are not aware of, and I think the fact should be known. And finally, just touching briefly on the theological and moral issue, the Vatican put out a statement saying that when ethically irreproachable COVID-19 vaccines are not available, in other words, a vaccine that was made without any ever use of any fetal cell line, but when that is not available, then it's okay, it's morally okay, morally acceptable is the word they use, to receive a COVID vaccine that has been used from cell lines from aborted fetuses in their research and production. This is a statement from the Vatican, and they are clearly making this statement because of the tremendous benefit compared to the risk of vaccines in saving the lives of of everyone, including their parishioners.
James, do you have anything to add on this?
Look, I think Sy's covered it off extremely well. I mean, the only thing I'd add is that I think it's important to recognise that as I alluded to, or made clear, that the abortion wasn't conducted to get cells for biomedical research. This was, it was done for medical reasons, and this is a subsequent use of that tissue. I think a useful analogy is to think of organ donation. If you consider someone who gets hit by a drunk driver and ends up in ICU with a traumatic brain injury and is brain dead, and the organs are given to someone else to save their life because they've got renal failure or liver failure and need an organ transplant. Those organs aren't morally tainted because of the original act. I mean, we're not conscioning the original evil in the car accident by using the organs for an organ transplant, and we can still derive the benefit, and it's morally acceptable to derive that benefit even in the face of the evil that led to them being available. And I mean, I would say that it's kind of similar with the cell lines. By taking the vaccine, you're not conscioning initially the abortion. And I would say that with the mRNA vaccines, it's a tiny part of the development process. I mean, the mRNA vaccines are not made in these cells. But even if they were, like with the J&J, I think it's analogous to that the organ transplant sort of situation. But as I say, it's an ethical issue, and it's not my area of expertise.
So let's move on to another objection, and this one has to do with younger people and vaccines and should they get it. So here's the whole way that it was put, and again, this is another paraphrase. Getting the vaccine seems to carry a higher health risk, rare but serious side effects for younger people than just contracting COVID. Very few young people have died from it. So is it reasonable for young people to reject the vaccine on this basis?
Well, the problem with that question is it uses a premise that's not true. The risk of side effects, as we discussed a little bit, and death and hospitalization for young people from getting a vaccine is far, far less than it is from getting COVID. So the beginning of that question is simply based on something that isn't true. Now, it is true that young people have a much lower risk than old people. I'm very aware of that, considering my own age. But again, the risk benefit for young people is in favor of the vaccine compared to getting COVID. So it's based on a false premise.
Yeah, look, I mean, I thoroughly agree. I mean, it's while the risk is lower in younger people, it's not no risk. So we often focus on the worst end of the outcomes with death. I mean, if we look in the US, there's been over 600 deaths in under 18-year-olds. So I haven't looked at the update of that for a month or so, but and we have been seeing an increase. There has been an increase in that since schools opened, and we've seen more circulation of the virus. But yes, that's still a rare event. But I mean, those are preventable deaths. There's also the morbidity, the risk of hospitalisation, and the morbidity from ongoing symptoms, so-called long COVID or post-acute sequelae of COVID, if you like, that also can have a significant impact on a proportion of children who have had infection. So I think we need to not just consider looking at death and hospitalisation, but we also need to consider the morbidity and the impacts on kids' schooling and all of those other impacts when considering the benefit of the vaccine. And I think there's a clear benefit with very small risks of the vaccine in this population. And that's been recognised by the CDC and the ACIP with making their recommendations. American Academy of Pediatrics have clearly supported the vaccine as well, on the basis that the risks of getting COVID far outweigh any very small risks of the vaccine, even in children.
Okay, so we've got 3 more questions or objections left, and then we'll close out this episode. So number 10 in our list here is, what about all the breakout cases? The vaccines aren't really doing their job. And I've got a personal anecdote about this. I had COVID fairly recently, and I got the double jab, Pfizer. I got Pfizer in April, and then I got COVID in September. I got COVID. My wife didn't get COVID. Both of my kids got it. But both my wife and I were vaccinated. And one thing that I thought was important to mention was that when I was in the middle of COVID, all the nurses and doctors that I talked to were kind of saying that there was actually a whole lot more breakout cases than were being reported. Maybe they didn't use that exact terminology, but one nurse in particular said that in her family, everybody was vaccinated and half of them got COVID still, which was basically the exact same experience that we had in our family. You know, granted, our sample size is not very big, and these are just anecdotes, but maybe it's the case that some of the breakout cases are being underreported, which I think is completely possible. But anyway, so what are your thoughts on this this question or objection? What about all these breakout cases? Vaccines don't seem to be doing a very good job of preventing COVID.
Yeah. So look. I mean, I'd go back to if we go back to the start of the clinical studies. So, I mean, the original desire for a vaccine was we were aiming for a product that was at least 50 or 60% effective and against preventing ideally severe infection. And I think the fact that we got vaccines that were 95% effective against preventing any symptomatic infection, I mean anything from a runny nose, a sore throat, a cold, right through to severe disease, was an outstanding achievement. Yes, we have seen a decrease in effectiveness of the vaccines against preventing any symptomatic infection, and that has been in the last few months and has coincided with the rise of Delta variant in the community. Now, it's a bit hard to unpick, but there's probably two different effects going on. So on the one hand, we've got Delta, which is a very well-adapted virus to humans. I think we've seen in real time, we've seen the adaptation of SARS coronavirus 2 from probably a bat host to a human host, and I think Delta is well adjusted to a human host. It is able to spread between humans much more efficiently than the original strains, and much higher viral loads are achieved. So that, I think that's a real challenge to the immune system when you've got something that replicates so well. We've also, there is some evidence as well for some degree of waning immunity, and this is probably seen more with the Pfizer vaccine than with the Moderna vaccine, although there's some evidence for both, and Moderna's just been approved for a booster dose as well. So I think, yes, we have seen some waning in effectiveness against any symptomatic infection. So that's the cold, sore throat, runny nose right through. But really importantly, we've seen absolutely no waning of we still see very high effectiveness of the vaccines against severe disease, of all the vaccines against severe disease. And this is the disease that we really want to prevent: those who need to go to hospital, those who end up on a ventilator, those who die. And I think this relates in part to the course of COVID. So the infectiousness and transmission and a lot of those cold symptoms occur early in that first week, and you probably need high levels of pre-existing antibodies to prevent that. Whereas the severe disease tends to occur a week or so down the track, and a memory response, a memory immune response from memory B cells that can start making antibodies, from T cells that can respond, is probably much more important for preventing that severe disease. And it's got an opportunity there's time for that memory response to respond and prevent the severe disease. And I think that's why we're seeing ongoing high effectiveness of the vaccines, because if we look at immunologically, and measure B cell responses and measure T cell responses and look at antibodies. Yes, we do see waning in antibody levels after the vaccination course with time. It does stabilise, but we see really robust memory immune responses, which is consistent with that ongoing effectiveness of the vaccines. The other point that I would make is that as we get more and more of the population vaccinated, a greater proportion of the infections that we see will be in vaccinated people, just because just by on the basis of the numbers of people who are vaccinated versus unvaccinated. So I don't think that's a very reliable marker to look at, whether people are the proportion of people who are getting infection who are vaccinated. Because in the ideal world, everybody who got infection and everybody who was admitted to hospital would be vaccinated, because the whole population would be vaccinated and there'd be no one who was unvaccinated. But what we do know from the monitoring data, there was a paper that's just come out in the MMWR that even with Delta and with waning immunity, there's still overall about a 5-fold reduction in the risk of getting infected if you are vaccinated in the United States. And there is a 10-fold reduction in your risk of hospitalisation and an 11-fold reduction in your risk of death. So you're markedly reducing your risk of adverse outcomes if you're vaccinated, and those levels of protection remain higher in younger individuals. There has been perhaps more of a decline in older individuals, and that provides the justification for the boost that has recently been approved by the FDA and recommended by the CDC for those older populations. And data out of Israel does suggest that a boost does reduce your risk of reduce the risk of infection, and even gives you even better protection against hospitalisation and death.
Sy, do you have any thoughts on this question?
Well, yeah, I think it's important for people to realize that in medicine, in general, it's very hard to use a black and white or all or nothing approach. Nothing cures everything. Almost every medication, every treatment plan fails at some point. So rather than talking about, did the vaccine fail because lots of people have gotten COVID after vaccination, that's not a very useful way to look at it. We really need to look at, the statistics, the scientific evidence, the risk benefit ratio, because you're never going to have 100% benefit and 0% risk. That doesn't exist in the real world. So if we think about it, not all or none, but, is this better than the alternative? Which there's no question that that's true. It's enormously better to get the vaccine than to get COVID, as we've been saying all along. Then I think we can avoid some of these misinterpretations and misunderstandings of what's going on.
All right, so I think we've got two more questions. So the next one is, what was the approval process for the COVID vaccines compared to that for regular vaccines? And if there was any differences, how would you analyze the risks arising from such differences? Sy, I think you mentioned that you've got a response to this one.
Yeah, there were no differences. The differences were simply, as I mentioned, the bureaucratic requirements. And anyone who's been following this story knows that the FDA and CDC, but especially FDA, has requirements that are somewhat bureaucratic. Now, they do come from good scientific reasons, and that is because the FDA is really committed to prevent disasters coming from toxicity of medications that they approve. So they're extremely careful about being safe, and that requires, since the people are largely lawyers and people who understand how to do this legally, it requires a lot of paperwork and a lot of forms and things. And what happened with this vaccine was the FDA was able to change its culture, so to speak, thanks to the requirements of saving lives and getting a vaccine out as fast as possible. And I agree with James that this goes to the credit of the president, President Trump, at that point, because he spurred that on, as did all the people involved in doing this. But those processes include starting out with a new drug application called an investigational new drug application. There are then clinical trials that have to go on in several stages. It starts with a very small trial, then there's a slightly larger trial, and then finally a third kind of clinical trial. Then there's a license application. The facility is inspected, where the people applying, like Pfizer or Merck, Pfizer or Moderna, have to bring in inspectors to look at their manufacturing facility. And then there are many other findings that go to a vaccine advisory committee, which, by the way, is not composed of government scientists, but is composed of independent academic scientists who review the data. And then there is lots of other things that have to go on before the vaccine can be used. And if you were paying strong attention in the fall of 2020, you would have heard reports about each of these companies getting to a certain stage in the process. Everybody was waiting impatiently for the approval. And as we know, the final approval for these vaccines, even after they had shown how well they worked and how safe they were, didn't come until, what was it, about a month ago by the FDA. So, yeah, all of those processes for vaccine approval were followed. But a lot of the bureaucracy was compressed. There was some compression of the clinical trials so that they could occur simultaneously rather than consecutively. And all other than that, everything else was done as always is done. So there were no steps skipped, there were no shortcuts made, and there was no safety issue that was not investigated.
Seems like a pretty comprehensive answer, but James, do you have anything to add?
No, I think that covers it off. I mean, I think
Sy's making your job easy today, James.
Yeah.
I was going to say the other way around.
Did you have something to add?
I completely concur. I mean, the process has been just as robust as usual. It's the FDA has maintained its independence from any political pressure, and I think it's a resounding a tick of approval for these vaccines that they're now fully approved. I mean, I do think we need to remember that, they were rolled out under emergency use authorization, and that's because we're in a pandemic and they were urgently required, and they've saved hundreds of thousands of lives as a result of that emergency use authorization. But they are now fully approved.
Okay, let's get to the last question, and then we'll move to some closing thoughts from both of you. So here's the last one. What scientific evidence, if any, is there that COVID-19 vaccinations reduce the probability of SARS-CoV-2 transmission?
Yeah, so look, I'll maybe kick off with that one. So firstly, as we've said, even though there has been some waning of protection, I guess particularly with the Pfizer vaccine, against symptomatic infection with Delta, or coinciding with Delta, there still remains a significant degree of protection, somewhere between 50 and 80%. So those infections you've prevented, and if you've prevented infection, then those people can't transmit it to other people. So just by preventing infection, you're preventing transmission. Of those who do get breakthrough infection, with Delta, it looks like there is similar viral loads at the time of diagnosis, as measured by looking at CT values by RT-PCR. But the dynamics after that differ, in that in those who are vaccinated, there's a rapid decline in the amount of virus, whereas there's a much longer tail in those who are not vaccinated, so suggesting that there's probably a decreased ability to transmit. There's a paper that's just come out or in preprint from the UK that has looked at the Pfizer versus the AstraZeneca vaccines and looking at prevention of transmission with Delta and including waning immunity. And they've have demonstrated a reduction in transmission in those who do get a breakthrough infection, more so with the Pfizer vaccine than with the AstraZeneca. And while there has been some decline in that in that protection with Delta, there's still a significant reduction with the Pfizer vaccine. If you look at contacts of people who have breakthrough infection who are vaccinated. So I think there's very good evidence that the vaccine does reduce transmission. That said, given the infectiousness of Delta, I think hopes for so-called herd immunity, where we get enough of the population vaccinated, we're going to stop transmission of the virus in the community, I think are now extremely, I think it's fanciful and extremely unlikely to think that we will get herd immunity. So I think people should be seeking individual protection, but I would reaffirm that by getting vaccinated, not only are you protecting yourself, you are protecting those around you and reducing the risk of, if you are infected and get breakthrough infection, you are reducing the risk of passing it on to those around you. And that includes those who can't be vaccinated, such as children, and includes those who may not derive as much protection from the vaccine, and thinking here of immunocompromised people who certainly should be vaccinated as they're at the really high risk of severe disease, but may not get as good protection from the vaccine as those who have got a intact immune system.
Well, Sy, unless you've got anything to add, we can move to closing thoughts. Okay, let's do that. And since James just went, Sy, feel free to share any closing thoughts about the episode today. If there's something that you wanted to mention that you didn't get a chance to during the show, feel free to mention that now, or just share a kind of summary of your thoughts. I did want to mention, and I should have mentioned this at the beginning of the stream, that we're not telling you what to do. This is not medical advice that we're giving you. We're just looking at the scientific evidence for and against the vaccines. So I wanted to make that caveat, and again, I should have made it earlier. But with that out of the way, go ahead, Sy, and share your closing thoughts.
Well, actually, yeah, I do have something I wanted to talk about, which is not science. It has to do with the reason that people seem to be very hesitant to get the vaccine or resistant to get the vaccine. And I think we can attribute that to religion, but it's not what we think. It's not Christianity. In fact, I'm not an expert in Christianity, but I will mention some very prominent Christians. I'm not going to mention all their names because it would take too long, but I'll mention a few names who have spoken out in favor of getting the vaccine, and that includes people like Franklin Graham, Robert Jeffress, a large number of pastors, the president of the Fuller Theological Seminary, people from the Southeastern Baptist Theological Seminary, the president of the Southern Baptist Convention, the general superintendent of the International Pentecostal Holiness Church, people from the Dallas Theological Seminary, Northeastern Seminary, Northern Seminary. Maybe I should stop because I have a list here of many, many more people, Christian leaders who have spoken out. The president of the National Association of Evangelicals, editor-in-chief of Christianity Today, and the president, and many more who I don't want to spend too much time. So this is not a Christian issue to be against the vaccine. The religion I'm speaking of is a very strange one. I don't think most people consider it a religion, but I do, and that is anti-vaccination. People who feel that there is something wrong, deeply wrong with vaccination. And this is an ideology that goes back to the 19th century, early part of the 19th century. And it was promoted largely actually by liberal reformers, political reformers in England, who felt that vaccines were just evil, putting something into your body that was dangerous. And in those days, of course, vaccines all use dead virus or sometimes even live virus. That's not the case today. But that deep philosophical or religious idea has persisted. And in fact, today there were people speaking up from this anti-vaccination movement long before the vaccines. They began speaking up even when COVID first came on the scene, and they were denying that it was a serious disease. And I believe they were denying it was a serious disease because they knew a vaccine would come along eventually and that would stop it, and this would damage their credibility. Now, one of the leaders of this movement, by the way, this is well known. I'm not making this up. It's not a conspiracy theory, but you can see it anywhere online. But one of the leaders and one of the biggest funders of this misinformation is Robert F. Kennedy Jr., who is the son of Robert Kennedy, and of course is a liberal. He's very pro environment, and he's very much against toxins in the environment. And he became an anti-vaxxer based on that. He misunderstood the issue of mercury in vaccines, and he went from there to becoming a very strong anti-vaxxer. And he, as I said, he has been promoting this spreading of misinformation along with many other people, none of whom are, at least the leading funders of this, none of whom are strong Christian evangelical Christians. So there are all kinds of motivations for this. I think that there's this religious fervor, and unfortunately, it has spread to some Christian circles, and I think that's a real tragedy because at this moment in time, and for the last month, the majority of, I believe it's the majority, I'm not sure, but a large number of the people who are dying from COVID unnecessarily have been Christians, and I find that to be a terrible tragedy. And I will just end by saying the reason I made the first video and the reason I agreed to make this second one is that I'm hopeful that if what James and I have been saying will get one or two at least, and hopefully many more people to change their mind and get vaccinated and thereby save their lives, it's worth it. And it's worth all the negative comments that we get from people who are not convinced. And with that, I'll end.
Amen. Okay, James, feel free to share your closing thoughts, and then we'll close the episode out.
Sure. Look, I mean, I think I would want to point out as well that there's been a number of Christians involved in development of these vaccines and supporting the development. I mean, I think the head of NIH and Francis Collins, Andy Pollard with the AstraZeneca vaccine. So, I mean, it's and there's Christian support for this enterprise. I mean, I think vaccines are one of the greatest public health initiatives of the 20th century. I mean, we saw the elimination of smallpox. We've seen the near elimination of polio. I think we forget what these diseases were like and what a scourge they were on humanity. I think vaccines are a great blessing on humanity. And I think that as Christians, we should recognize the blessing that science is, that God has given us inquiring minds. He's given us a rational world that we can understand, and that he can bless us through science and medicine and through vaccines. And I mean, I think that the vaccine development against SARS coronavirus 2 for COVID has been a huge scientific success, and we should see that as a huge blessing from God. I'd also add that we shouldn't just be thinking about ourselves. I mean, thinking of this from a Christian perspective, that we're called to love our neighbour, and we see the parable of the Good Samaritan, thinking about who our neighbour is, and through getting vaccinated, I think that's the best way at the current time that we can show that we love our neighbour, by preventing the risk of us getting infected and passing it on to those around us, whether unwittingly or if we have symptoms. So I think from a Christian perspective, I think we should regard this as a great blessing, and I think we should regard it, getting vaccinated, as a way to, as a Christian response to show our love for those around us in our community.
Well, I think that's going to do it for us today. So thanks, James and Sy, for coming on. Especially thank you for your closing thoughts. I think both of you shared some really important things there at the end. And James, I kind of want to have you back on the channel, maybe to discuss something else related to Christianity. But you and I can talk about that a little bit later in email. But yeah,
sure.
I'd love to have you on back on the channel if you're open to it. And Sy, obviously, Sy, you'll be back, and we're going to continue to do work together. So I don't think I need to mention that here. But anyways, thank you guys for watching. Hopefully this is helpful to you. Maybe it might even change your mind. Who knows? We'll see. But let me know, as always, your thoughts in the comments. And until the next video, signing out, Cameron Bertuzzi with Capturing Christianity. Hey, it's me again. Actually, don't leave yet. I've got something super, super important to tell you. So first of all, you're awesome. Like you just watched a really, really long video just now, and you're still watching it. That is actually pretty amazing. Secondly, we have hundreds, literally hundreds of other apologetics related videos for you to watch on our channel. Go check them out. I've interviewed exorcists, hosted debates between Christians and atheists. I've even made response videos to atheists. All of that is available on our channel. Go check it out. Third, I rely on people that see value in my work, people like you that watch videos to the very end, to keep the lights on around here. Literally, this is how I feed my family. So if you see value in the work that I do, please consider supporting this ministry and becoming a patron. Links to that are in the description. Oh, and have I mentioned that Christianity is true?